I'd like to discuss a fun new paper that was just published in March 2021 on the usability of electronic health records in the United Kingdom emergency room departments. And this was published open access, and it's a short paper. I think the actual text part is only 5 pages. And so go ahead and get your own copy and read the whole thing. It was written by Dr. Benjamin Bloom, Jason Pott, Dr. Stephen Thomas, Dr. David Gaunt, and Dr. Thomas Hughes. They're all out of the United Kingdom. And what they did, in short, is they surveyed 1,500 emergency room physicians of all levels of training and used a standardized tool called a System Usability Scale score, which is a industry vetted, meaning it's been used really since the 1980s in a whole bunch of different industries and across many different types of technologies to evaluate the usability of these systems. And they collected this data, and then they essentially looked at the systems which had more than 20 respondents per system. And so they looked at 15 different electronic medical records used in the emergency departments in the United Kingdom. And they studied what their findings were in terms of the median system usability score. And their conclusion, in short, is that the usability sucks, which is really not a new finding for anyone who's been using these systems. But the great part about this study is that they were able to quantify the usability of these systems using a validated metric called the System Usability Scale. And they were able to produce objective statements, such as to say that 3/4 of all the systems in the UK fall in the lowest quartile of cross-industry toolings. Or they were able to show, for instance, that pretty much none of the systems used in the UK fall in the acceptability range in their median score, and the rest are either not acceptable or marginally acceptable. And so this objective data is really great. And the other finding from this study, which I find particularly interesting, is that they were able to look at the same electronic medical record system and to evaluate how its System Usability Scale score varied when it was installed in different health regions. And they found that there was a statistically significant difference in these scores for the same electronic medical record when installed across different types of health regions, which is a really important addition to the research, because this is something we know subjectively, which is that depending on how you configure and you install an electronic medical record, it can very dramatically change the perceived usability experience. And this paper helps add some evidence to that effect. So why don't we just look into the paper in a little bit more detail here. So in terms of the methods, what they did is they sent a survey to around 8,000-9,000 members of the Royal College of Emergency Medicine in the United Kingdom. And roughly 1 in 5 people responded to the survey, and they tried to write the survey when they were advertising this in their newsletter and online as objectively as possible, in terms of that they're just conducting an informational survey about electronic medical records. As we said, they got 1 in 5 people responding, 1,600 responses, and they threw out only 5% of all the responses because they were either incomplete, or they didn't actually comment on an electronic medical record, or they commented on an electronic medical record, but not enough people in the survey also commented on that same record, and so they threw out those where they had only received 20 or less responses for a particular system. In terms of where they received responses from, as you can see here, they received responses from all throughout England, and then a few from the other parts of the United Kingdom. And if you look at the range of people who responded. You got a nice variation from everyone from, junior trainees up through, I guess we'd call them residents here in North America, and then ultimately consultants. My largest critique of this entire paper is that the way that the BMJ formatted this table 1 is horrendous. It gives the illusion, and I initially screwed this up when I was reading it, that if you read count country across the top and you look at England, you see the number of responses. Then in column 2, and then I was trying to figure out, why did they only have FY2s respond in England? This doesn't make sense. Why did consultants only respond in BCD? Anyway, these are actually 2 separate tables, or 2 separate parts of the same table, and the first 2 columns form one table, and the second 2 columns form a separate table. And the number of responses links to the grade, the number of responses links to the country. You need to see this visually in the paper, or if you're watching this online, you can see it right here in the video, but his table is extremely embarrassing to have been published by BMJ. Anyway, let's move on. What type of responses did they get? Well, we have the actual breakdown of the top 15 systems that they received feedback on. As you can see, you have many systems which are more common here in Canada or the United States, such as Epic, Cerner, and Allscripts, Meditech, and then you have, of course, a plethora of other systems which are much more common in Europe or in the UK, such as DXC, IDGen, InterSystems, Nerve Center, System C, etc. Most of the responses, and it's easier to see this in the table, came from people using EMIS or Symphony, and then those using Cerner, and those using DXC. For the American audience, Epic actually received a reasonably low number of responses. They had only 32 responses, and that came from only 3 organizations. And then, as we mentioned, for each particular EMR, they were able to calculate the mean system usability score and then an interquartile range for that. And they had, of course, a confidence interval on each system usability score. Now, it's sometimes a little bit easier to visualize here on this point and whisker plot. And what we can see is that we have the electronic medical records on the bottom. We have plotted up the vertical axis, the system usability score, and we see that all electronic medical records fall below this dashed line, which is the average across industries and projects and constitutes a low margin of acceptability. And so I believe that was the score there at 68. 3 systems happen to have their confidence interval extend above 68 if you kind of included the upper part of the confidence interval. But again, I don't know how much we should put into this, because some of these systems like Epic and Meditech also had much smaller sample sizes in terms of the number of people that responded, and they had fewer numbers of organizations they were implemented in. I think the big takeaway is that no one's really a high achiever or performing particularly well in this study. We'll look at the system usability scale and how it works and why it's such a useful tool in another video. But I think one of the interesting takeaways, if you wanted to look into this in a little bit more detail, is that there seemed to have been, among the physicians who replied, a high level of perceived confidence in their ability to use these systems. So people would rate themselves from 0 to 5, with 0 being strongly disagree and 5 being strongly agree. And you see a lot of 4s in here, where people will say that they feel that very confident using the system, or I learned to use the system quickly. Or if they were asked to respond to the question, I need support from a technical person to use the system, people will rate it lower, such as a 2. However, even though people perceive that they feel confident in using the system, And they responded in general saying it wasn't particularly hard to learn the system. They still say that they find the system to be unnecessarily complex, and that there's too much inconsistency and it gets cumbersome to use. Now, let's dig into one of the other key pieces from the supplemental materials that we mentioned earlier, which is that they were able to actually produce data showing how each different EHR provider in their study had different levels of integrations across all the different sites and regions. And so most of the systems perhaps had someone either having to look into a separate system to get X-ray results, to log into a separate system for blood work, or to log into a separate system for both blood work and X-ray results. There's only a few systems where everything was linked. And so there is an interesting question on how much is the perceived usability of a particular EHR system influenced by the need to log into peripherals, blood systems, lab systems, pathology systems, and how much of that integration or lack thereof of integration is a function of the actual electronic medical record, and how much of it is a function of the implementation of that medical record at that site, and how much of it is a function of the peripheral systems which are used and their inability or ability to be linked to the medical record. And so I think this is an important nuance to consider, because if we were to take a takeaway from this paper, we would realize that the usability of these systems is very low. And then I guess the other point just on this one, is that there's also a high variation in the need for people to log into separate systems to get notes for outpatient visits or from general practitioner visits, or versus inpatient visits. And so one of the, I think, interesting takeaways from this study is obviously the raw data that they've provided about the system usability scale, that essentially, 3/4 of all the EHRs used fall below 55, which is considered to be the lowest quartile in general of technology studies. So we're using really low quality user interfaces, and they're not really at all considered acceptable. But the thing which I'm finding interesting is this kind of ability to actually speak to, in a research study, the heterogeneity of how we perceive a particular EHR vendor and how this varies depending on what we've plugged into in terms of integrations of that system. This is interesting to me for a few reasons, and people like Raj Ratwani have been doing far more research on this, but the same EHR system can have huge variations, and this was shown in one of Raj's papers from a few years ago, in the variation in the number of clicks you need to make to achieve an outcome. And this is a lot more up to the actual implementer in terms of the decisions which were made. So this might be related to the health informatics team at your local hospital or regional health authority. It might be related to what fields have been made mandatory, which forms are mandatory, which systems they have integrated or have not integrated, how the workflows have been researched or designed. And so when physicians are frustrated about the lack of usability of their clinical systems, the reality is that no silver bullet is going to fall from the sky. There is no great new electronic medical record which we can all install in our hospitals and clinics kind of next week or next year. But we can make changes at the configuration level of these systems and the implementation level of these systems. And this is 100% a target I think that physicians should be putting pressure on in terms to improve the quality and the output of how usable the systems are. So although it's in general unrealistic to expect that hospitals are going to change their particular electronic medical record. There's so much sunk cost in the cost of these systems, et cetera, et cetera. I think it's really reasonable for institutions to think about how the configuration can be improved in as straightforward a manner as possible. And there's, I think, a lot of low-hanging fruit which might be able to be achieved at that level to improve the quality and the user satisfaction. And then you could use a tool such as the System Usability Scale scores to be able to perhaps track over time if the perceived usability of a system is actually improved after you've been tweaking the implementation and configuration of it. In terms of other things to say on this topic, I wrote an article on the blog years ago where I actually timed the login times for trying to log into the electronic medical record in the emergency department at my tertiary hospital, which was the largest hospital in the city I was working in. It was a big emergency room, and to try to quantify the millions of dollars in opportunity time lost, or opportunity cost lost, waiting for physicians to log into an electronic medical record because the login was so slow. And again, that's a configuration issue. That's not the software necessarily itself. That's the way that this system was set up. And so in theory, this is something that could have been fixed. And so I'll link that within the article associated with this video if you want to read how to quantify that. But again, this is an interesting article. It's short. You can read it cover to cover. I recommend, if you do, to get the version with the supplemental materials direct from the BMJ Emergency Medicine Journal, because it has some interesting tables at the back with regards to how these systems were actually implemented and some of their variations. Nice work.